right, well, I think we'll go ahead and get started. We are so lucky to have two providers here with us from the Maine Med Pediatric Clinic. Brandy Brown, LCSW, is the clinic coordinator for the program and is one of the therapists at Maine Med's adolescent psychiatric practice. Brandy has worked with within several acute systems there, including psychiatric inpatient hospitalization, residential with vulnerable populations, homeless youth, severe psychiatric disorders, and neuropatients. She's there for the LGBTQ community for as long as she can remember. As a member of the World Professional Association of Transgender Health, thing we'll look into, especially after today's talk, National Association of Social Work, where she's the current chair of the LGBTQ advocacy. We're also lucky to have Eimicke, nurse practitioner. Toni has been an MMP PEDS endocrine for the past 8 years, about 7 of which spent working with transgender patients. She got SN from UMass Amherst and her MSN to be pediatric nurse from NYU. She's a member of the Pediatric Endocrine Society, and she's the secretary for this group on transgender health. She's co-authored several publications, and recently she presented and participated in a panel at the international meeting of the Pediatric. Thank you so much. Here.
Hey, well, good morning, good afternoon, happy lunch. We are combining a couple of talks here, and so we're going to do a 2-hour talk in 45 minutes for you all, leaving probably no time for questions, but we'll do our best to see where we are. First set here is to really look at, no conflict, to really look at sort of conceptual framework of gender and sexuality. For some of you, this is going to be just a refresh, but we find you got to start with a good base before we move on from there. So just thinking about terminology, documentation. Want to spend some time talking about our process and our clinic, and then talk a little bit about the primary care with transgender youth. So hopefully those objectives make sense to you. It's hard to talk about.
Oh, I just know from Closure Road that they can't hear it.
Oh, I'm on.
It should be out.
Break my mouse. I will speak up.
Or I may not be doing it.
Oh, there might be no audio. Okay. You give me feedback. Okay. So here's the sort of the alphabet soup of so the LGBTQIAP population. That's who we work with in yourself on that list somewhere. Like it will be at least down if not somewhere else. So I think just remember the diverse population, and there's a lot of different technology that you use, and some of it is about sexuality and attraction. And so thinking about romantic and sexual attraction and orientation, I always like to point out that bisexual people are often invisible in any sort of data point ever. They're either lumped in with heterosexual or homosexual, and so we really don't get good data for them, and I think they're overlooked a lot in sort of primary care settings and healthcare settings in general. So keywords, most of those should be familiar to you. I think just to note, so pansexual, I think especially youth, you'll hear a lot more youth who are like, I'm pansexual, and you're like, oh, that's great. Sure. Yeah. Tell me more. So more is basically they're not really a gender factor in their attraction, but they may have attraction qualities like physical characteristics. Asexual, always a lot of kids to say they're asexual. They're not interested in sex. They're not interested in thinking about sex. Why are you put them in a category? And then when we move on to sexuality, we think about gender. And I always like to break gender down to the biological, the sociological, and the psychological. So we got the chromosomes, the hormones, what your body likes. Generally, when you're assigned to sex at birth, it's related to what the doctor sees. And we're going to pronounce you as a boy or a girl. Somebody's going to smoke a cigar and be happy. And then, okay. Yeah.
It's still very difficult to understand.
Okay. Well, I don't know how to go any. Hold this here. I'm going to use it. So, see now. So sociological, I think we're looking at sort of perception, labels, grouping, how we see people in society, how we treat them based on the assumed that we give them. When we see someone, just to note sort of the LGBTQ population, that's really a sociological grouping. Those folks don't necessarily have much else to do with each other as far as a group other than how society treats them and the discrimination that they've dealt with. And then psychological is really that internal sense of self, how you see yourself, understand your gender that's affirmed. I'm going to put hands here. So some common terminology, and there's a lot of debate over what's the best words to use, but we've been going with sex assigned at birth. Instead of saying sex, just so really clear, we're talking about sex that the doctor filled out at your parents when you were born. Gender identity, like I said, that's internal. Always want to make a note about intersex people. They're often categorized in one group or another, although like New York is now putting intersex on birth certificates, for example, so we're sort of understanding that population better. So that we obviously having the chromosomes or gonads of both sex. Let's see, transgender, so that's the sex assigned at birth, does not align with your gender identity. So cisgender is when it does, and I think sometimes we sort of skip the cisgender word, but so you're probably transgender or cisgender or intersex person. And I think it's important to sort of delineate that there is the trans doesn't just mean this big difference over here. There's something to do as well. The MTF and FTM, I think it's important to you really just have to look that last word, the last letter, the F. TF just tells you to treat that person. So treat them with as much respect as you generally treat women. Hopefully isn't that different from how you treat men, but it might change some of your language or how you say gentleman when you're introducing yourself. So non-binary, sometimes you'll see words like genderqueer. There's lots and lots of ways that people define themselves, but 30% non-gender, 30% of transgender people do see themselves as non-binary. So that's a category that's just going to keep getting larger and larger. So folks who could static gender identity, you could see it very clearly, or it could be kind of flowing in a spectrum. We'll look at that in just a minute. Visuals, I think it helps me kind of understand. So when someone's transgender, they do a lot of different things. So sociological groupings, some of those are biological. Those are sort of someone identifies themselves or how other people have grouped them. So I think that's just a helpful way to remember. It's an umbrella term, and it really relates to everybody, even who's under that umbrella. So let's see. Terminology, we think about affirming. So we thought about affirming. Our clinic, we are an affirming clinic. So if you say, my name is Susie and I am a boy, I'm going to say he. I'm not going to argue with you about who you are. You need to be what women here for. I think the big thing about affirming is that affirming, you're accepting someone without judgment, and you have a positive regard for LGBT identities, which is not the same as I'm okay that those people. I see those people as positive, as people who have value to society, who want to work with, not as some other. So I think that's the big piece about affirming, is that you do see people with a positive regard. An ally is someone who shows support and respect to the LGBTQ community. So ally is someone, it's really an action step. It's someone who's willing to maybe take some of their privilege a little bit and help others. Not necessarily somebody who's going to, well, I got just having a sticker somewhere that says I mean, I see ally stickers all the time, and I love them, and they make me very happy. But When that means I expect that person to step outside of their box, me or for this community as needed. Misgender is, now we have, our kids are always worried about being misgendered, so we've got to identified by the wrong gender, and it causes a lot of stress and distress that you might not really understand what's happening for them. A lot of our kids work really hard on passing. Just there's a lot of pressure to present as a certain gender so that other people can get it right, so that they don't have to experience that distress. Sometimes you might hear someone say they're going stealth, which is so nobody knows. In a community, there's kids at school who are stealth, nobody knows. So that's sort of extra considerations. Those kids are usually really anxious about people finding out all the time. I have a kid I'm working with who's and is trying to figure out how to not be stealth and how to, because it's so stressful for him, and it's been stressful for multiple years for him, and he doesn't think he can come now as fans to his friends. What's that is real process of sharing your identity. I don't know how many, there's a lot of data on how many times somebody comes out, but people come out over and over and over and over. It'd be nice if we could come in as well. Or maybe everybody else had to come out and we just all came out. So, closeted, choose not to reveal your identity. Some people are closeted at work, they're closeted at school, but they might be out with their family. They might be closeted with their family and at work, fluid, so that's that identity that could change or shift. And queer, little asterisk on queer because I don't really need to use that word as much as I want to understand it. So queer is a lot of people identify this way, and if someone's identifying that way with you, that's okay to use, but it is a pretty offensive term that's being reclaimed. So there's a bit of privilege to that term of the people who are using it or reclaiming a hate term. And then gender dysphoria, which is really a diagnosis. It's a self-diagnosis. We specialize in at our clinic, and it's really about the distress caused incongruence, and a lot of it's come from external sources with I guess body and mind, and really intense feelings, intense disconnection there. Pictures. I like pictures. These are some symbols you might see stuck on people's cars or on flyers or on Holly's pen here on her badge. So the one here, this is gender pride flag, and this is the LGBT flag. This is the symbol for transgender. Here is for the Human Rights Campaign, which is the largest lobbying and advocacy group. Put that here because you'll see the equal sign a lot, and that's kind of where the equal sign came from. It's been around for, I don't know, 40 years. So I gave you this handout, the genderbread person. I really like the genderbread person. It's a nice way to kind of break things out. So identity, action, express really what's outside and sex. And I think just kind of break it all down that these all connect because it's all the same genderbread person, but they don't cause the other, but all connected. And then, so just to give equal opportunity, we also have the gender unicorn. So I guess nice, I think, conceptual frameworks. I think are ones you show a patient or a child, and it's not super hard to understand the point. On days I like different one, I guess. So, and if you find a better one, please feel free to pass it my way. To give a little data on the U.S. Transgender Survey 2015, this was released in December 2016 with an executive report in the study. And this is the first time, no, this is the second time we've had a major study on transgender people nationwide. The first time, I think there were about 6,000 people involved. This has an of 20,000 plus people, so the data was close, but it was much more valid having a much larger N. So see who took that survey. So it's third, like I said, about a third of non-binary people saw themselves as gender, and then women. So, yep, sure.
People with transgender men is male or?
Yes.
Yeah, okay.
Yes. We always look at that last word is the,
Okay.
I think, is the one you kind of key in on. And then if you go backwards from there, I guess. So of those folks, just a couple interesting things, like 30% of these people have had a legal name change, which means about 70% have not. I don't know if that comes up for you folks. 11% had their name and gender marker changed on all their IDs. So there's a lot who've had name change, but it didn't get sort of over on everything. 32% of people who said their name and gender marker were not correct on their IDs faced harassment, which physical assault or denial of services once that was disclosed. So once somebody saw ID and saw that it was different. And how does that us here in healthcare? You can't read that very well. So there's a whole slew of negative experiences that people report seeing. And the questions were in the past year. So in that past year, a whole lot of concerns. So 24% of people on the survey said that they had to teach their healthcare provider about transgender people just in order for them to get the care they needed. And these are folks coming in they're not coming for to specialty, they're just coming in to get care. Something really interesting is, we think everybody must tell us the truth, and we've got our data and our EMRs are all perfect, and documentation, I'm sure you have no glitches there with yours. We've got like 3 in our system in there. But folks are not, 1% of transgender people are not out to any of their healthcare providers because they don't feel that healthcare providers would be safe to come out to. That's a big number, I think. 6% are not out to all of their providers, so they might be out to their primary care, they might be out to their therapist, but they're not out to sort of everybody. And then we've got 23% who said, like, well, they're not even going to, we're not going to see anybody, we're delaying care, maybe they're getting internet medications, they're doing what they can to avoid sort of our healthcare system in general. And that's because of fear of mistreatment. There's another subsection of folks, a third of folks didn't see a healthcare provider because of cost. So they did sort of break that out. Let's see. So a quarter of them had a problem with their insurance and getting things covered. For example, 25% of those folks were denied coverage for hormones. And 15% of folks, I only have 2 slides of percentages, okay? 15% of folks said that their provider asked them intrusive questions that weren't related to their actual care. So that's our tips for suicide risk. You can really talk about a transgender population without looking at their risk. There's a 4% lifetime suicide attempt. Sometimes that's a little higher, but the general population is 4.6. So we're talking about a pretty significant. I think only other population with a similar lifetime suicide attempt rate is veterans. So it could be other high populations. And 7% of folks who took the survey said that they had made an attempt in a year, and population is less than 1%. So, just to think about like how these folks are getting support. 15% said that a provider, a healthcare provider in that past year had tried to get them to stop being transgender. So that's pretty scary to me. So things we have to kind of overcome. People are walking in your door with a negative experience already. They're carrying that in with them. Probably took some time before they decided to walk in. There's a delay accessing care. There's a delay in opening up. I mean, in pediatrics, but older folks are going to be much less likely to open up just based on experiences with society. With larger system, I'm in a really system, but you're in a pretty big system here too. A lot of challenges because the people get treated different ways through different parts of the system, or you collected the information and like, why don't you know this? I've already shared that like 6 times. That's sort of what we need to be trans-aware providers, but we also need to work to make sure our whole system is moving, which is probably have Toni and I here today, and Dr. Belfort coming next week. I want you some hope from the Joint Commission, because we all love the Joint Commission, and they're thinking about this too. And this is just one of the many pieces of evidence that they had about put the preferred name prominently in the patient records so that we don't set it up. And so it's nice when you can have the Joint Commission thinks this is a great idea. So I love everything that they do. Mention on the broken arm syndrome. If anybody's heard of broken arm syndrome, it's my favorite diagnosis. It's not my favorite diagnosis. I'd like to have it not happen. It's when somebody comes in for care arm and they see the person at check-in, they see the MA, they see the doctor, they see et cetera, and every conversation they have to have is about their over and over, and so they never really get to the X-ray or the cast. I mean, it just takes so much longer, and so that's part of it. And then the other part is, or it's all related back to all their gender. So your arm is broken. I think it's because you're on hormones. We should probably stop the estrogen. Or, you know, your mental health crisis, and I get this a lot of people, like, I think we should stop the hormones. This is kids in crisis. Like, could we look at like 47 other factors that are going on? But get the call of like, well, we're just crisis or hospitals saying we're just going to stop testosterone because that's it. Might be, I mean, we're all like holistic beings, so, but it shouldn't be the main event. So let's see. Showed on communicating, I think, you know, open-ended questions. What do you need to know? You're going to make a mistake. We're people. We all make mistakes. That's like part of how we're wired. We're also wired to learn, so just apologize and move on. You don't apologize over and over. It's a one-time shot. I'm sorry. I move on. Try to write after you apologize. That's much better than explaining how you got it wrong. We were talking to somebody this morning, and she's like, you can always make it awkward, right? So you want fun. That's pretty big stuff. Please, I don't know if you guys do this. So transgender is not a word that has ED at the end ever. Really, you like hit with the transgender stick and become transgendered. So that one, I think we see it all the time in literature. So it's totally easy to pick up, and you think it's sort of this descriptive ED. And when you use transgender, it's not an A transgender. It's a transgender, a male, adolescent, old person, whatever. So that's the big spiel on language and things. So now we're going to move. Put on a different hat. So, how to referral to us at the Gen Clinic, and these handle sheets that you got, referral guidelines. So, and there's, I don't know, the whole system in place. I think you probably had other talks about the guidelines. So, it's not supposed to be comprehensive. It's just supposed to be general. Like, why would I send the kids to these people? So it looks like yours probably reads easier than mine. So we want to just make sure risk folks. You know, behavior's coming up. Parents have concerns. You might notice something. Not saying maybe tons of distress, but just kind of like some things. Maybe you send them to us. Maybe don't. That sort of depends. That's an assessment you'll make with there. There's some resources. I just put a couple on here because you can see it's tight on there. But, you know, just find some resources maybe. Let people know that there is a gender clinic. There's, you know, these are resources in the community. And then we do more risk. We're seeing maybe kids are at 10 or 2 puberty, and Toni will talk more about that because that's not my expertise. But they're starting to have a little bit of distress. You see mental health comorbidities. Maybe there's some conflict in the family is not really accepting, or maybe one parent gets it and the other parent's really struggling. So the real, and then high risk, women the high suicide risk in this population. So we want to make sure if you do have a kid who, and this does happen sometimes, someone's sending to us who's got that, so make sure you give me a call too and say why this is a pretty high risk kid. I think that's the big thing about referring and letting us know, because we might not be able to get them in right away. We do have kind of a day in getting folks in, so we make sure we're working with you to figure out how to help those high-risk kids. Again, more intense distress around puberty, thoughts of self-harm. Sometimes you have kids who are harming their genitals, so that's always concerning. And most of this, I think we should have covered in the first half things. Just a quick note about who the Gender Clinic is. So we started seeing kids in 2009. We were working between kids from Boston who were living in, started having a collaboration between endocrinology and psychiatry practices that got a little more formalized from a consultation to maybe some ongoing consultation. In 2015, we said this is really a clinic, kind of started putting that as the name out there. This amazing was hired to coordinate the clinic so that we could be all together. So we have psychiatry and social work. We have clinical ethics as part of our team. We meet weekly, so we're going over cases and trying to figure out how to help kids in the community beyond our care as well. You got referral process. This number is on the website, so yes, you can give it out. It's an intake with psychiatry first. I don't care if you have a clinician you're working with. That's the process. You really don't want to have to go through a whole mental health assessment with an endocrinologist. So, I mean, you'll have a great time, actually. But, you know, we want to make you a little uncomfortable, at least, with psychiatry and ask intrusive questions while you have a physical exam. And we work with the family to figure out if, so our question, if the referral comes to endocrinology, the question for us is really if that's going to go. And sometimes I determine that with the family before the mental health intake, and sometimes we figure it out after. And it's got a different path, so we have to kind of those things in. I haven't really figured out what a typical case is yet, but we're working on that. We're working on typical. And the reason we have a typical case is because of a lot of people. So this is where we were August of last year, and then August of this year we exceeded all of last year in referrals. So I'm sure you see a number of those here. So we've got 250 some kids that we're working with. We've had a few more. I haven't gotten the data for September and October, but I can assure you it keeps growing. We'll definitely have over 100 referrals this year. So that is a sign of having a in the community that people can reach out to. It's a sign of having providers feeling more comfortable with having conversations with kids and families, and a sort of society being more open to really looking at gender and exploring that in a safe way, regardless of the politics. People always ask me, like, well, how old are the kids you work with? So we do have a 3-year-old. Over, but other than that, in this data yet. So this is a quarter 12 and under. So we're kind of pulled out. That's age 4 to 12, and the rest of those are 18 plus. So people are a lot more comfortable once we get to the teenage years to send over to us. But we want to make sure we're helping the kids right before puberty instead of waiting until they're halfway through. Sometimes I get asked, so assigned sex at birth, that's the one the doctor yelled out when you were born. And so it's about a 2/3. I think we're seeing this thing this way, and I expect we'll get closer to half. I think a lot of that is not necessarily about who's more likely to experience gender dysphoria, and it is probably more of a reflection of who's more comfortable getting their kid help. And I think we just have a lot of stigma around boys who present more feminine then how we're gonna support them. So this is Toni's part. All right, turn it off. Turn it back on.
Quiet talker, I definitely need it.
Yeah, you're gonna have to hold it. You're gonna have to hold it.
Your voice isn't.
I know. Oh, I know. All right. So I know I don't have a lot of time, so I will be going probably fast. My goal was to take something away from this that you can use practically in your day-to-day life. I'm not going to teach you how to manage from an endocrine standpoint and get them through this journey, but I thought if I were a primary care provider, what would I want to know and how can I help patients? In our world, the two major guidelines or standards of care that we use to guide our practice are the WPATH standards of care, which that was mentioned. Brandy has it here if you want to take a look at it. And then the endocrine guidelines, which were gently revised, and the revised version was published in September, just 2 months ago, of which the Pediatric Endocrine Society Transgender Health Special Interest Group took part in, which was very exciting. And lines have a whole section outlining the differences and the updates between the new guidelines and the previous. And one note in the new guidelines, so actually a step back, I like to point that even though these are endocrine guidelines, the first sentence, the first you'll read, talks about mental health evaluation and the importance of mental health involvement in the care of these patients. And so the initial evaluation, as Brandy mentioned, always involves meeting with our child psychiatry team. In some clinics throughout the U.S., they don't have child psychiatry. They may have a psychologist or a social worker. In some capacity, it's really important that these patients meet with mental health advocated in the guidelines. And the new guidelines actually outline criteria to assess the training level of mental health professionals, and I apologize for the typo. But it's very also encouraging to show more of the mental health involvement, and also, lastly, the multidisciplinary team approach that we have, and it's invaluable. We, Brandy said, meet weekly, and those meetings are such an important part of the care for these patients. When and if the patients do come to see us in endocrinology, what that looks like, as Brandy mentioned, we affirmative approach to care. It's guided by many patients, but we in the Pediatric Society did publish a statement on the gender affirmative approach care, which if you'd like to take a look, I think we in response to some of the issues around bathrooms and some of the issues that states have been dealing with the past year or so, and then it became such a useful statement in those situations that we felt it'd be helpful to publish it. So what else do we do in endocrinology? So of course we deal with puberty. That's a thing. And so first intervention typically is pubertal suppressive therapy, and then may or may not then also go on to seek gender-affirming hormone therapy, which is formerly known as cross-sex hormones. It will probably be known as something else in the next year. Terminology is ever-changing. We offer guidance and support through other aspects of transition, such as you mentioned, school name change. We're a resource for many other aspects of their care. And we help for referrals when and if appropriate. So in the guidelines, the major statement option is that adolescents who meet diagnostic criteria for gender dysphoria or gender incongruence, fulfill criteria for treatment and are requesting treatment, should initially undergo treatment to suppress pubertal development. So that's their support of suppression of pubertal development in these patients. criteria. And so the physical changes that occur during puberty can be variable for many transgender youth. Maybe not all, but many, and that's been our experience. Hormones. It allows time to expand the diagnostic phase, allows time for kids just to breathe and explore their gender without worrying about the changes that are rapidly happening, although it isn't as rapid as they think. But to them, it's pretty dramatic and pretty stressing. And the guidelines do support and suggest suppression in earlier stages. So by 10 or 2, there's no to support suppressing or doing any interventions from an endocrine standpoint prior to that. But I will mention that there are some cases where we see beyond 10 or 2, and we still do start suppressive therapy. So at least 10 or 2, reminder what that is, and preceding pubertal suppression, we usually have that mental health assessment. In this, Brandy's triaging these referrals. She might talk to the family, and this kid might be in such distress that we decide on a case-by-case that it makes more sense to come see us first and start that process, because it can be actually a lengthy process just to get the blockers or the pubertal suppressive therapy initiated. So these patients will typically experience worsening of dysphoria, that distress, with the onset of puberty and progression of pubertal development. And these treatments, this would not be something that you would need to go over, but I think it's important to have some knowledge so that you can let them know what to expect and answer questions, general questions they might have. We'll review it in great detail with the family. And the medical options include injection versus an implant. And the insurance company, insurance coverage often dictates which one we choose, unfortunately, but that's the way it goes. And these are what they typically look like. The injection is Blueprint Depot, the pediatric formulation, and the primary care practices may often be requested to administer these injections. They're very well tolerated. They don't typically cause hypersensitivity reactions or anything. The major reaction that we warn people about is what's called a star abscess, so like a local reaction. So these are very safe, well tolerated. It's an IM injection, and so we'll talk about what can primary care offices do. Be aware that this is something they might need, and if parents know ahead of time, I've had a few families say, my primary care is right on this journey and said they'll do whatever we can. So it may seem like something really simple, but just even offering for that injection to be done at the primary care office can be a big step showing that you support them. Implant, there's either the Suprelin or the Vantis. They're the same medication, same dose, same delivery system. It's just they're marketed for different populations. So the Suprelin is marketed and approved for use in children with puberty. Vantis is used for men with prostate cancer, and the price difference is tenfold. It's for the Suprelin and $3,000 for the Vantis. So it's these are high-cost drugs. Hence why we try to get the process going with insurance coverage as early as possible, because it can take a lot of arguing to get the coverage that they need. So endocrine, we will go over the potential risks. Again, in the short term, pubertal suppressive therapy, or as people often call them, blockers, very safe, very well tolerated, reversible. But in the long term, the major risk that we do discuss is bone health. So 80 to 90% of total bone mass is acquired by the end of pubertal development, and that's because sex steroids play a major role in bone myelination and bone growth. Once we block those steroids, that increases the risk for bone mineral density loss. And that we in endocrinology will be worrying about and caring about in greater detail than we expect primary care to, but what you can do, practically speaking, is reinforce optimizing calcium and vitamin D, and I did include a link here going over FDA recommendations and sources of calcium and vitamin D, both dairy and non-dairy. So, and again, it's something we will discuss. But so pubertal suppressive therapy or blockers are not standalone long-term therapy. You either need to stop them or add in the sex of the identified gender. So the next step on there with us, typically, but not always, is initiation of gender-affirming hormone therapy. So prior to that, we usually have many times, or at least a few times, and discuss their case with that multidisciplinary team. Confirm that there's persistence of gender dysphoria or gender incongruence. There's this detailed discussion that occurs in endocrinology of the risks, benefits, and effects of these treatments, and we do consent both from the patient and parents, unless the patient's 18 or older, then we just themselves. So guidelines suggest a starting age of 16. That's been controversial, but it's not adhered to. And the reason 16 was for the guidelines is in part because it is most adolescents have the mental capacity to give informed consent by that age, but it's also because a lot of these guidelines developed from where the age of consent is 16. So in reality, a lot of patients, well, not a lot, are compelling, as they mentioned in the statement in the guidelines, to start younger than 16. I won't go into great detail, but for example, in our trans females, if you have a patient who's going to be on A for a long period of time and B potentially really tall because we're blocking pubertal development, they're maybe tolerate prefer as a trans female. That is one of the many reasons we may discuss starting at a younger age. Also, we're starting them at pubertal development at an age when their peers have completed it. So it's also putting them behind their peers. So guidelines do include this statement that says we recognize there may be reasons to initiate treatment prior to age of 16 in some adolescents, even though there are minimal published studies of gender-affirming hormone treatments. So that's what they could do without firmly saying at younger age. So we'll take it. And then typically what it looks like, I won't go into great detail, but feminizing treatment usually includes estrase. So there are some positions where we will use transdermal or patch. I've never used parenteral and intramuscular in some clinics. I know they do. We may or not have them on a blocker depending on when they come to us, whether it's covered for a variety of reasons, and may have them on spironolactone, which is an androgen blocking treatment. So if we are able to get the or GnRH analog treatment approved, there's no need for the spironolactone. And then treatment includes testosterone. Typically we administer it a weekly subcutaneous injection. It used to be administered intramuscularly, but studies of which we've been a part have shown efficacy and superiority, at least from a patient's perspective, of weekly injections versus every 2-week or monthly IM injections. And that's, I want to mention, another area where we might call on the help of more so the nurse, most likely, to help teach patients how to administer these injections themselves at home, because that's what we do in our clinic. But again, some patients are more comfortable receiving education from their primary care practice. So we use the gel or the patch, testosterone patch, but again, less commonly used. And also, much like with the feminizing treatment, that we may or may not have them on a GnRH analog to suppress pubertal development. Typically, though, when you get to the testosterone levels to a certain point, one of the main goals of masculinizing treatment is to stop periods
the other goal is to sterilize and allow for more of a male appearance. And so you can achieve that alone more readily with testosterone than you can achieve the effects from estrogen alone for a feminizing regimen. And the other issue with estrogen alone is you usually need to use much higher doses to press their testosterone level below a point where we want it, and then that increases the risks of blood clots and other issues related to estrogen. And are we out of time? So this is a nice chart. I'm just going to go through and some other primary care considerations. One last thing I just want to mention, if I plug it in there. So if you wanted to look through these slides, I did discuss some primary care health concerns specific to transgender females and males, things they might come to you about that you wouldn't have thought about because it's not something you typically think about in other populations. So again, with transgender female estrogen, there is an increased risk of blood clot, especially if they're on higher doses of estrogen. Sclerosis, it may be something they come to you about because they're more comfortable with their primary care than they might be with us, and that caused in tucking practices and not a lot of good literature about standards of safe tucking practices, and that's when they tuck their testes into the inguinal canal. So there's less stability, but the UCF website has a great database of reasons. I liked their link on testicular pain. So think about, and I learned a little bit about other types of cancer screens here, and as well with transgender males. Now, I wanted to touch base about with regard to males is that they're coming to see you and you're planning to eventually, well, you're planning to send them to our clinic if they're having dysphoria or distress around their periods. There should be no reason if they want them to be stopped that you should, unless there are medical reasons that they can't be on a treatment that can stop their periods. You should focus suppressing their periods either until they come to see us or if they ever want to see us. And I created based on some literature that I found looking at the effects and benefits of different treatments to suppress periods because people ask what's the best way, what is the best option, and so this is just something for you all to take with you and do. And so I won't go over it in more detail, but as always, if you guys have any questions about any of that, you can always feel free to email me or email me. I'm happy to answer those questions. Thank you.